Thank you both for your lovely presentations. Now we're going to have the first round of question and answers for our panelists, and we'll take first the questions from the audience, and then we'll ask some questions that we've got on Zoom as well.
Whilst we get organized, I have a bunch of questions for Mike. Involvement of the community. Has the community been involved in the discussions with the regulatory so far? And how do you want to go about this in the future?
So
it's active.
Yeah. So there's different ways to be involved. So in regard to interaction with the regulatory authorities, thus far, there hasn't been at the level of GRIN Therapeutics, but each of the authorities have mechanisms by which they, in a new area, they will engage with formal meetings with different groups. So the US has these patient-focused drug development sessions that can be requested, and these are very formal interactions. There are opportunities, I believe, similar opportunities in Europe for to engage with the EMA on these topics. So in our situation, as we have had some early interactions with different authorities, we have had patient involvement in some of our programs, just early conversations, but never in a more formal way yet. But there are a lot of ways to do that, and I would say, given how new this disease area is, or I would say you should explore those things.
Okay, no, I think it's a very good thought for us to really get and reach out actively to EMA and other or national agencies. And
I would just add that part of the reason why, we don't encourage folks necessarily to go with us to these interactions, because then they say, they're just doing it because they're with them. So from our standpoint, I just point out that it's there, and then it's a matter of you all to decide what the right, because we shouldn't be influencing that. Your policy should be how you engage about us.
If I remember correctly, we actually wrote a letter to the agency, to the European agency as GRIN Europe, to actually support your work, because I remember. So I think it's very important that we advocacy groups are out there and saying, yes, we agree with what's going on, what this company is doing, and we really want to encourage this type of work.
May I ask another question right away? What about the radiprodil binding site? Are there, wherever it binds, do you know where it binds to the GRIN receptor? And are there compensatory mutations that may go with your pathological mutation that would then make radiprodil not effective?
So we know where it binds, and based on when we assess the variant and we assess where the mutation is, we do know where there's the potential that there would be potentially lack of effect. That's not something, based on where we've seen so far, it's not been a factor being predicted to not bind and have an effect in the setting of gain of function.
I have a question about radiprodil. Did you have information about its activity on intellectual disability, which is not only the epilepsy which is involved here? Does it in vitro increase LTP or other measures of that?
So we have not had yet animal model data to indicate any changes in behavior. And at this stage, we have numerous seizure models where it's clear that there's an effect in vivo. And we also have clear effect in GRIN 2A model that shows increased survival. From a behavioral perspective, that's area that it's often hard to assess whether there's going to be a benefit. So we don't have anything yet in that area that would, but it's based on the biology, based on the disease. We're evaluating. That's part of why we wanted to evaluate it in behavioral disorder early and have a cohort specifically focused on that.
Yes. Yeah. Hi. Hi. What? Okay. Thank you. Actually, for both presentations, there was not very much discussion of design, so to speak. And especially for the first trial, I don't know exactly what the anticipated number of inclusion will be for the second one because it's ongoing. But what's your opinion, both of you, on using alternative design, SCATs, N of ones, and really trying to increase the yield of randomization and blinding in a multiple one setting? And also, even if you have 23 patients open label, would you not analyze them as individual results and present them as such instead of going for group results? Because at the end of the day, we want to explain why certain children respond and others don't.
Yes, thank you. Well, in fact, we will analyze each patient. I don't show that results, but when we are in our proper, I hope so, publication, we will show each individual results. Yes. And
for instance, if you show that some cognition is improved through the Baileys and there's your main effect on your primary endpoint, I think most parents would like to know, is there in which children is the effect on cognition associated with daily functioning, for instance?
Yes.
And I would always sequentially sort of present them in 23 lines. Is not so easy, not so difficult to comprehend in a publication. And I think it's much more informative than any group result, to be honest. Yeah. Yeah.
Is under second. The papers is under our second revision in BRAIN. I hope it will be accepted, and we have detailed everything. Every single child has been very nicely detailed in every aspect, right. And there is a table and supplementary material besides. So, yeah, it is true that there is a big difference in the response of L-Serine depending on the child, and in particular, and Natalia mentioned that very well, depending on the severity. So mild patients tend to respond very well, and one of the children involved, it was a very high impact regarding the autonomy that she had. So she was able to.
This is a patient with a GRIN 2A variant that she's a patient with at the beginning with a borderline intellectual functioning, IQ of 82, I think. And this child really improved around 20 points of, 20 points in the IQ. And this patient now is study a basic degree, and she's really autonomous for every daily task. She can take train, manage money, have a social life, yes. I think that is the most impressive improvement in our cohort. In the graph that I show in the mild group, mainly there were 4 out of our 5 GRIN 2A children, and the other were GRIN 2B. 4 GRIN 2A and 5 GRIN 2B. So by the moment we can assume that the most important variable for improvement is the baseline severity. But yes, I don't know.
Yeah, I think it is important to analyze every child in detail. Also, if we had biomarkers. Also, she didn't include other information in the presentation, but we had like a baseline blood test with several parameters, and after also the concentration of amino acids before and after. We have stored in our biobank some samples just to do lipidomics, for instance, or other things in the future. We also had an EEG, a conventional EEG, not the high density that the machine broke down, but the conventional before and after. So, and these, we hope that we could do some analysis, some quantitative analysis also on this data that is not included in this first work. So, yeah.
And so I think also it's mostly the journal that this determines also some of these. But in our view, and I don't know whether you agree, but it's just open for discussion. In any kind of these kind of trials, we should shift from describing efficacy to understanding why a child responds.
Sure,
and that's
sure.
a very different concept and a very different design.
Yes,
and it's a big change in the field, I think.
Yes, yeah, well, we totally agree. And that's the future of the personalized medicine. Yeah, sure. Thank you.
Sure. No, I mean, just to add, it's limited I could add to what's been said. I agree that, you know, as you see some of the elements that I described in the study, we're going to look at behavioral versus, of course, seizure cohort, but also in our case, we have every variant is characterized. So we have variants, and it's typical to look at each individual patient and their course and see if you can determine responders and non-responders, and you look at the and you know, we look at various parameters. So I completely agree that you want to, in a small study like this, do some of that and then test those hypotheses in the bigger study.
But then a block design, so ABA or a single case experimental design, same trial would tremendously increase the potential to make those claims.
Yeah, I think there's a variety of designs that we also are looking at to try and make sure that we allow as much open label treatment as possible, minimizing placebo. There's a variety of things we want to consider as we put these studies together, but they're all great suggestions.
I have a question. First of all, congratulations to Dr. Julia and Dr. Garcia on your trial. This is very exciting. I wanted to ask your thoughts on whether it looked like most of the severe cases were GRIN 1s, and maybe L-Serine doesn't work on people who have a GRIN 1 variant. That's where the site is. So maybe there's something unique about those patients instead of it being the severity of their symptoms. Maybe it's the variant. And also I wanted to bring up the possibility you'd mentioned about a lower dose. There is this phenomenon with high dose of glycine that the receptor internalizes. So it may be that if you go too high, that maybe you actually lose your effect because now the receptor is internalizing. So just those thoughts. What are your thoughts on maybe GRIN 1? It doesn't work as well as 2A or B.
Well, in general, they are really more severe than GRIN 2 patients. So they have the functional and the structural abnormalities in the brain are really greater. So some of these patients even had migration cortical malformation. So these kind of things are really very difficult to change, no matter the treatment that you give, because it is something that prenatally has been, damaged in a very important manner. So I think that's a major problem in GRIN 1.
That time pattern expression could be maybe the GRIN 2A are very important in the prenatal life. So maybe.
Yeah.
I have many questions, but I confined to very, very few. First of all, do you know the concentration of serine in the cerebrospinal fluid in those patients? How much it was increased?
That's an important question. So we use the regular dose that is using in amino acids, not only in L-Serine, but in all kind of amino acids that we use normally in inborn areas of metabolism. And this is like a safe dose and something that we have been given to patients for a long time ago. We didn't check at the same time the CSF because it is something like invasive and aggressive for the patients. In the same time, even we don't hope to have a very high concentrations in the CSF because in the blood it increased a little bit in post dose, but it is not a lot. And even we had this information. We don't know exactly which is the D-serine that is converted into L-serine. We did that once in the first in the proof of concept in the N of 1, where Xavi and Dr. Soto did a lot of basic research. We did a CSF in the patients and in the number 1 patient, but then in other patients, like a patient with primary deficiency of L-serine synthesis, before and after, we measure L-serine concentration and also the enantiomers, L and D-serine. We measure also sphingolipids and other things that behave on the pathway of L-serine. And then, well, yeah, we have an increase, but we don't know if this is the best increase that the optimal increase that we should have. You know, we are working on safe doses. This is our major goal. I know that for other trials, we know that for other trials, L-serine has been increased up to 800 milligram per kilo per day, and even in primary defects, you can go to 800. I mean, yeah. That's the information that we have.
For me, being an electrophysiologist, a concentration of 1 micromole means good information what's going on. Like, you know, if you take a good dose of glutamate and eat it, nothing will change in the brain. No change, virtually nothing. But
yeah,
I don't know how.
In glutamate, you have a very important peripheral metabolism that will eliminate. Yeah, glutamate.
So
yeah, for
I
glutamate,
wonder
what
about the concentration changes. And
yeah.
you know, in ideal situation would be to compare 23 people with same mutations 1 year later without treatment and with treatment. So when you know you have the clinical experience, if you take this group, would you expect any form of development even without any treatment?
Mm-hmm.
Do you know what? If you know, one would like to see a comparison of same group with same mutations,
yes,
with treatment and without treatment, so you can identify what was the result of the treatment. For many reasons you can do it, but as a clinician, you may have the experience. What is the likely development of kids with these defects in a year, which was the duration of how long you. I would expect that some development may occur, and what you see is not only an effect of serine, but rather effect of normal
neurodevelopment. Sure, for sure. Yeah, whatever treatment you use, that will happen. Yeah, for sure, because this is not a progressive or neurodegenerative as other diseases. Sure.
What has happened when you finish the treatment after a year?
Yeah.
Do you follow these patients?
Yeah.
And is there a regression, or is it stable, or what happens?
Yes. There are some patients that now that have during the trial an improvement and now discontinue, but the improvement remain stable. Yes.
Yeah, and for some patients who discontinued the treatment, they had like an increase in irritability or sleep disorders. Some patients had even a loss of some functions, although most of them remain with the gains that they had. Some had some problems like irritability, sleep disorders, and a regression, small regression for some of them who stopped the treatment.
Sorry, for the sake of time, because we're going to have a roundtable discussion. We can keep on talking about this. We're going to take 4 more questions, but let's make there also. Yeah, but a lot of questions. I know. Because we have to go on a break, because that's what it's scheduled. First in 20 minutes. The break is in 20 minutes? Oh, sorry. I'm sorry.
Thanks. So I have a first one. I want to add a bit more on radiproteic mechanism of action. Then I'll have a question to Natalia. So the question where radiproteic binds is actually very important because there is a specific site on the receptor that is very different from where memantine binds. Memantine goes into the pore of the channel and act there. And radiproteic act actually on the outside of the pore and is an allosteric site, it's called. And the reason why is that it's very important is because 80% of the mutations that give gain of function, they are actually in the pore and do not disrupt the binding of radiproteic. So I think that there is a differentiation versus memantine that it's actually more stable, the binding, and it is not altered by the mutation. A question now to Natalia. I think it's very interesting. I mean, the data, and thanks for sharing all those details. A question about the specific mutations, because we make distinct categories, loss of function, but they're all very different, and there are lots of nuances. And I know that it's very difficult, but I'm wondering if it's very difficult to find specific correlation between genotype and phenotype, and even so more for drug response. But I'm wondering if you look at that in more details, in terms of any mutation that give rise to different response, and maybe in particular the patient had an overt reaction or actually didn't had a lot of adverse event. If there was any, did you learn anything about the mutation particularly?
We don't have a clear relationship between phenotype and genotype. I don't know if Mireia or Xavi wants to add something about the functional.
Yeah, if I can add some. Sorry. Yes, if I can add something. So the genotype phenotype correlation is not yet defined. The number of genes that are involved in GRIN1, 2A, 2B in this cohort is too small, and not only because there are 3 genes, but there are also different domains that are affected. So this is like we are talking about GRIN-related disorder, a loss of function, but indeed it's a spectrum with developmental dimension, genetic dimension, and structural dimension. So this is super complex. We're really waiting for this natural history and having the studies of these international studies led in the States by Tim Benke and Trinalis that will provide a bigger N sample size to make this correlation. So, but yet we do not have this correlation. And oh yes, Mireia.
Just that something is that it does not depend if it's affecting the trafficking or what the domain. It's more related to the severity, the improvement, or not to the subunit. I mean, GRIN1 are really severe, but for the other ones are not related to the traffic, the binding site, or the mutation. So it's more related to the severity.
So, sorry, can I keep the microphone just for a question? Okay, so it's related to the binding sites. So I think that something that I would like to answer your point, Amy, is very interesting to think when we were thinking about D-serine efficacy or L-serine transformed to D-serine efficacy. This was one big concern that we had, but then we realized that supplementation of L-serine indeed is acting mostly on wild-type receptors. So the point that perhaps is not useful for GRIN1 mutations, which is true, but in a context of just one allele that is affected, we don't mind that much. And the second question related with this is about radiproteic and radiproteic binding site. So I think, yes, most of, as you said, most of the mutations causing a gain of function are in the magnesium binding site. And I think that you're really good at defining a positive allosteric modulator because, well, from the structural models and from all the genetic information that we do have, this amino-terminal domain is mostly polymorphisms are neutral. So probably you can be very safe that if it's again a function, radiprolil will be correcting. But I have a question regarding radiprolil binding site. So it's pretty close to other domains of the NMDA receptor that can be modulated also by natural allosteric modulators, protons and polyamines. So do you know if there is some interaction somehow on radiprolil or modulation of the endogenous binding sites? I don't know if something is known. So did you try to modify proton acidity or polyamines levels?
No. 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 So for those online who couldn't hear it, we don't really have any specific information on that.
Okay. Yeah, because my point is that perhaps in the synapses of green children, we always do the experiments and we place on standard conditions, but that I don't know how the extracellular medium or the metabolism is it in that context.
That'll play out in the basically as we treat more patients, as we collect information with and without radiprolil. That'll be part of what we'll evaluate. Whether how they respond and whether and how different variants respond. So that'll all play out.
Maybe one because I know that there are.
There's one more comment.
Maybe one thing to specify, because they are negative allosteric modulator, they are pH dependent, and this is not the case for radiprolil. This activity is not dependent on pH. So because that's one feature of other compounds, and of course in vitro, there are other things like magnesium that of course impact whatever physiological readout. But I guess that's not was your question.
Hey, good morning. First, my name is Remco. My daughter Tess has been on L-Serine for about 2 years now. I have some questions on the trial. So first of all, thank you for leading it. It's really nice to see real development of drugs for our kids. I know that multiple clinicians have been gathering data on L-Serine, also Johannes Lemke and Clara van Karnebeek, and I suspect there's more. Is there a plan to combine all that data and to show better statistics?
Well, in our publication, we will publish our series of patients, but we add also 10 more patients from worldwide. So for increase the knowledge, yes. Yes, there are patients from
many places.
From Italy, there are a lot, Brazil, there are.
Yeah, during the trial and even before starting the trial, because it was something that it was known because of the first article, and we just were contacted by many doctors, also by Clara van Karnebeek and by many others. They contacted us. We shared our protocols with them. Some of them published their results independently. Some others shared the information with us, and we invited everybody to join our publication and our work. And in plus supplement information, it is included in the paper also. And yeah, in the future, we should join forces and work together for sure. Yeah.
And perhaps a question from a parent perspective. So also for me, but also parents approach me and they have a mutation and they figure out it's a loss of function. And then they want to know, hey, can we now take L-Serine? Is it and will it be also funded and prescribed by our doctors? What is your take on that? Could this be taken to the European Medicine Authority for approval? Or do we need to have a higher bar for that?
This is like a medical food, an amino acid, and the regulation is quite different than the regulation of a drug. And there are even different agencies here in Spain and in Europe and in other places. Since this has been already approved as a medical food and it is widely used in a number of conditions, there should be no problem for the prescription. The main point is who is paying for that. And yeah, because it depends on the countries. For instance, in our country, it is covered by the public health system because it's a medical food, it's an amino acid, it's a supplement that we give in other conditions. So it is the hospital who send the product, who send the treatment to the house of the patient directly. So the patient has to do nothing at all, not paying for that, not going to the pharmacy or whatever. He receives the treatment at home. But in other places, it's quite different. I know that in Greece, for instance, because we receive many mails from many doctors abroad, in Greece, it is even not authorized. Yes. It is not even not legal. It is illegal. So it's like crazy. All these kind of things have a bizarre regulation that it's sometimes in the middle of nowhere. And I think that in this case with L-Serine and other treatments that could be similar, we have to work together and to create guidelines and recommendations that are now with this paper and others. I think that we have our strength and our evidence is higher. So what we have to do is any kind of treatment that we want to test, we have to do like very well designed clinical trials, and the results have to be very, very well explained, and then create evidence just to have this support from the authorities finally. But it
has changed its goal in that respect. So they now want the natural history being related to the interventions.
Yeah.
So your chances, that's what I also mentioned yesterday, if you have a good collaboration and not 3 natural history studies, but 1, you can even incorporate L-Serine in the natural history study. Then these things change, and automatically countries like Greece and also the Netherlands can benefit from that, because then there's sort of a natural history trial, so to speak. And I think that would be really an instrument to harmonize efforts and to mitigate political interest.
Yes. Yeah, this is true.
Hi, I have a question about the L-Serine results. Did you notice that the efficacy was sustained throughout how many years? Is there reason to believe that with what we know of acclimation, especially to something that, like you said, is amino acid, that there may be a cliff to the results?
If the efficacy is sustained over time,
yes. Yes, we evaluated at 3, 6, at baseline 3, 6, 12 and 15 months, and we find a sustainable improvement. Yes.
And even for those who stayed beyond the clinical trial for a longer time, the efficacy was sustained. Yeah.
Okay. How long is the longest?
How long is the longest follow-up that we have? 2 years?
2 years. Yes, around 2 years.
Yes.
And does your work suggest that will continue? I think that within the community, some of the patients have observed that after about 18 months to 2 years, that the kind of gains that they saw from L-Serine may start wearing off. Do you guys have reason to believe that that's the case? Or again, is this because the variants present so differently that it's hard to make an assumption?
We really don't know. We really don't know. What we tend to do now is to go to slow the dose a little bit, and even for those patients who stayed for a long time with L-Serine with good results, we can recommend to stop for a while, 3-4 months, and evaluate them again and see what is happening. And then maybe we introduce it again in the future a little bit later, or just, there are also other treatments coming on. So, I mean, it is a little bit difficult just to create I think that we have to create like a common strategy with like many different experts who will be the next steps, even in a consortium, or because these are decisions that are complex, and we need also like some more basic students about, as Dr. Renzi mentioned, about the internalization of the receptor, for when it's going to happen after it's the dose, it's the time, and so yeah.
Thank you. And will those specifications about dosing be included in the publication?
Yeah, yeah.
Thank you
yes.
guys for your time.
But we have experience about many other treatments, not supplements, but drugs that behave on receptors, anti-epileptic drugs and anti-psychiatric psychiatric drugs and these all these kind of things. And some of them are taken like forever. But well, it depends on the component. It depends on our patients are in the process of neurodevelopment. So it is also something to take into account. So there are like many variables that make things a little bit difficult. Yeah.
We have a lot of questions today from our online participants. So let's give them the last 4 or 5 minutes here. The first one was from Elabel. There's a case in the literature where a GRIN 2B patient with gain of function responded negatively to L-Serine treatment.
Yes.
Are there any other cases supporting the avoidance of L-Serine treatment in patients with gain of function?
No, the main indication is to be sure that it's a loss of function. Yes, we are aware about this patient. And we know that this patient rapidly worsen after the beginning of L-Serine. So it's necessary to be sure that it's a loss of function. Yes.
Yeah,
it was the only
theoretically, it is not an indication for L-Serine if there is a gain of function because you are stimulating a channel that is already hyper stimulated. So it's like going on the wrong way. However, I mean, who knows that if they're in a particular patient, there are other conditions, other variants, other compensations just to keep the homeostasis, as Ilga mentioned yesterday, which is our main issue.
So that's the only patient that we know of that has tried and had adverse effects. Okay, that was basically the question.
Well,
oh, yes.
Okay, there's somebody from audience mentioned that there was a case in Israel as well with the gain of function patient didn't take well.
Okay. Thank you.
Okay, the second one is also about L-Serine. A mom from UK would like to know if there are any doctors that she could see about doing a treatment with L-Serine, or does she need to get to Barcelona?
No.
No.
It's only the doctor can write to us, and we can share our protocol and the indication. Yes, and everything. It's not necessary to come.
No, not at all.
And we'll take one more on L-Serine, and then we have a few on Radiprodil. Are there any experiences in L-Serine study with the kids with keto diet? And what was the youngest kid known to that have received L-Serine successfully?
The younger patient, to age.
2 years.
2 years. 2 years old, yes.
And did you have any on the keto?
Keto diet?
Yeah, while
no, we think that we received some information about a patient with a keto diet who had a refractory epilepsy.
Yes, but from our series.
But from our series, nobody was on keto diet.
In general, in our series, they have a well-controlled epilepsy. Yes.
The question for Radiprodil trial, if the drug shows positive effects with the Radiprodil treatments on 1 or 2 patients, but not on others, how might this impact the trial's progression? Would the development and further trials of the drug continue despite mixed results for those patients that benefited from the drug?
Well, I mean, we'd have to, it's 1 or 2 out of 24. I mean, being honest, that would be very difficult to have, an authority agree to take it forward simply because of the variability of seizures and clinical course itself. We would need to understand, was there really something specific that benefited those patients or something that specifically went wrong on the other patients, and then make a decision. But it's very hard to, it's about benefit risk of the cohort at large. And as we talked about before, we'd have to evaluate individual patients, but it would be very hard to take forward a program where only 2 patients benefited in an open label fashion.
Thanks. As we have several other questions, I think we'll keep them for the roundtable since we run out of the time.
Oh, sorry. Yes. I had a question about the timescale of effects, and I guess this is mostly for L-Serine, but I guess it would also apply to Radiprodil in the future. If you take, I don't know, what is it, 5 grams of serine in the morning, I would expect that your serine levels in the brain by the evening would have increased already. So do you have any sense of how quickly you start to see benefits? Have you ever considered or carried out maybe a Bailey test or a Vanier test, whatever, literally the day after the first dose of serine? And also, I guess the same to Radiprodil. Do you have any concept of what timescale you're expecting to begin to see effects?
Yeah. Yeah, what we see in our patients in general, they start to have some effects that are noticed by parents on a month, but even before. And also, if you take that as a healthy person, we did that. Chavi and I, we were control for the first study, and we took our blood and we did something, and we took a high dose of L-Serine, and it was wonderful. I mean, it was absolutely wonderful. So I felt like being 20 years old or so. I had my thoughts were like so quick and connected, and I was able to relate anything, and I was even a little bit scared of of going too quick, too fast.
It wasn't ketamine, no.
There is a clinical trial that L-Serine. There is a clinical trial where L-Serine was used with cognitive.
Yes. It has been already used
in healthy individuals for pro-cognitive effects. Yes.
Yeah. Yeah. Probably. Yeah. It makes so it's because L-Serine has different effects. It's not only an NMDA agonist. It has an effect in energy metabolism, in complex lipid pathway, and glucolysis, and different metabolic pathways. Is a very important molecule in life. Serine is a small molecule, but very important. So it is probable that some of the very early effects you have due to this neurotransmitter effect, but then you have a remodulation in your membranes in your neurons, and also a different type of energy consumption and whatever, and that causes different effects over time. That we don't know. It's just an hypothesis, but yeah. Yeah. Yeah, but from time to time.
I'll
For the
say
difficult days.
The question. So I mean, to your question about Radiprodil, I mean, we there's been extensive work in rodents and dogs and monkeys, and we know that it reaches peak concentrations at about 2 to 3 hours in the tissues, and actually dosed twice a day. So you'd expect to see something relatively quickly. In fact, for the study itself, we actually are doing on each patient gets an individualized dose escalation to target a certain receptor occupancy throughout the study, and we'd measure that relatively early after starting dose.
Yeah, I guess because the cartoon mechanism is there's more serine, it binds the receptor, the receptor increases function. But of course, many I'm immediately thinking of things like Prozac. It prevents serotonin reuptake, but actually more serotonin is good, but that's not actually how it ultimately produces effects. It changes the number of receptors and so on. So it could easily be the case here as well. But if you see an effect within a day, then maybe it's not. Yeah.
Before we break, I would like to just make a point on how important it is to have clinical trials. And